Thank you for coming in here to listen to us, and we hope to add evidence to what you all already know. I'm going to start us all off by just talking about the evidence behind perioperative hypotension, the need for better monitoring, and then I'm going to hand it over to Dr. Davies here, who's going to really take us to the next step, which is being more proactive in management of hypotension rather than being reactive and going into the predictive side of management of hypotension. These are some of my disclosures. I'm going to really talk about the blood pressure journey today. So every patient that comes and meets up with us in the pre-anesthesia clinic or the preoperative holding room or in the operating room really starts a blood pressure journey with each one of us who practices anesthesia or even practices critical care or perioperative medicine. And our hope is that as patients make their transition from the operating room to the PACU, to the hospital ward, or to the ICU and finally go home, that we can actually keep them safe during their blood pressure journey. That is our hope and the whole reason behind all of this evidence that we've been trying to produce. A very basic thing I'd like to say from the get-go is when people talk to me about hypotension, they often come up with a singular number and say the MAP was 55. Well, that does not make much sense. I'd like all of you to rethink that concept and understand that in isolation, hypotension as a number is probably irrelevant. We need to always talk about the amount and duration of hypotension and absolutely like an area under the curve phenomenon. I'm going to go back in time and start with some evolution of how the data that we know today has sort of come out over the years. This was sort of the one paper that talked about the empirical definition of hypotension. Walsh, primary author, Dan Sessler, senior author, 33,000 non-cardiac surgical operations at Cleveland Clinic. And they were able to establish, and we always knew as anesthesiologists that hypotension was bad, but they were able to establish some sort of a numerical association. So a map of about 65 here on the x-axis is where the probability of harm associated with hypotension started, both for acute kidney injury and myocardial injury. Very importantly, they gave the amount and duration factor a true value. So right up on your slide, you see the 1 to 5 minutes right here. So a single minute of exposure to hypotension was associated with harm. And some people might say, wow, that's exaggeration. But I will say that if you look at all of the single minutes of hypotension you and I have for an average 2-hour duration of anesthesia, you'd be wondering what we do with our patients. Remember, this is a map of 55, though. So 1 to 5 minutes under a map of 55 associated with about a 30% increase in the odds of cardiac complications and acute kidney injury is very significant any way we look at this data. The other question that is always asked of me is, my patient's hypertensive, came into the operating room with a blood pressure of 160 over 100, where do I keep the map? Well, we've tried to answer that question at least retrospectively. So again, Cleveland Clinic data where they compared a 25% reduction from baseline versus an absolute MAP of 65 or less, and found no difference whatsoever in the amount of harm associated with either of those target parameters. Now, I will say that I am a believer in precision medicine, so I am not a believer in the one-size-fits-all model. Here is the data with MAP and MINS. Here is the data with MAP and AKI. The problem with baseline, at least as of today, is that we don't really know what an accurate baseline is. Is it the blood pressure that your patient had when they had white coat hypertension and walked into their primary care physician's office a week before surgery? Is it the blood pressure they had when they were super anxious in the preoperative holding area? Or is it really their blood pressure that they maintain on an average at home doing their normal day-to-day work? I would say option number 3, but we don't have a great way of assessing baseline pressures. In the absence of that, my guidance to all of you would be to stick with 65, at least for now. And that's exactly what these authors said as well. Going on further, we've tried to explore the whole concept of MAP versus other components. And we did come up with some guidance in this publication where a MAP of 65, a systolic less than 90, a diastolic less than 45, and a pulse pressure less than 35, were more or less equal in the amount of harm associated when each of these exposures was looked at for at least 5 minutes or more. Now again, we all know these numbers. It's not that we don't react to a systolic less than 90 or a diastolic less than 45, but it's important to keep these numbers in perspective as well, along with a MAP, because you don't always get the opportunity to have a measurable MAP in front of you. Timing of hypotension is extremely important because it's the one thing that we as anesthesiologists can control. As this elegant work from Kamal Maheshwari showed, peri-induction hypotension. Push some propofol, walk away, intubate your patient, surgeon's prepping the abdomen, everyone's talking to each other, next blood pressure is 80/50, everyone's still talking to each other, next blood pressure is 70/40, then someone picks up a stick of phenylephrine and corrects it. But the harm has already happened. A third of all hypotension happens in the peri-induction period and is independently associated with AKI. So for all of us who feel that we can make a difference, this is truly an opportunity to make a difference early on during the induction of anesthesia. Now I'm going to go to slightly larger data sets. So I started with about 30,000 patients. We have recently replicated the same work in more than 500,000 patients. So this data set, we started with more than 600,000 patients with a commercially available data set in the United States, and came down to about 370,000 patients where we looked at intraoperative hypotension and outcomes. What we were able to establish, just as big highlights, was number one, no age seems totally immune to the effects of hypotension. I've been asked this question again and again, and at least retrospectively, as associations, I can show you that whether a patient was 18 to 40 years old or 71 to 80 years old, there is harm all the way through for thresholds of MAP less than 75, less than 65, and less than 55. Furthermore, and I'm sorry for the slightly cluttered slide here, on the left side here, you see a primary outcome and different ways of measuring hypotension. If you look at literature, people measure hypotension in several different ways: time-weighted average, absolute maximum decrease, area under the curve, absolute cumulative time. We did all of them together and found really no difference again. No matter how you measured hypotension, the harm signal was fairly obvious. We looked at a lot of secondary outcomes as well. I'm not going to go into all of those right at this moment, but I'll say that our biggest primary outcome was MACE events, that's myocardial and cerebrovascular adverse events, and there was a strong signal of association of a MAP less than 65 intraoperatively with postoperative MACE events. Now, taking a little switch out of the operating room, intraoperatively, our patients actually do pretty well. If you look at intraoperative mortality data, it's next to negligible, especially for elective surgery. However, about 4 million patients across the world die every year in the postoperative period. If I show you data from the United States, it is still the third most common cause of death in this country is the 30 days after surgery. So we're doing all of this great work in the intraoperative period, operating on sicker patients, older patients. Clearly, they're not doing well, and they're not making it home. And what are some of those reasons? One very obvious reason, as shown right here, if you follow the red line up that depicts myocardial injury, is that the risk of myocardial injury goes up right away on post-op day 0. Now, keeping the perspective of perioperative hypotension in mind, understand that intraoperative hypotension plays a strong role in this evolution of myocardial injury. Myocardial injury is also dangerous because it doesn't manifest as chest pain and EKG changes all the time. So silent myocardial injury, lots of harm, and then I take you to postoperative hypotension. And the reason I take you to postoperative hypotension is because postoperative hypotension also happens really commonly. Another cluttered slide, but what I'm trying to show you without going into the depths of the numbers here is that in a 70,000 patient data set, we were able to establish harm associated with postoperative hypotension across several different outcomes, most strongly with acute kidney injury. Again, understand that postoperative blood pressures are not measured very frequently. So our data sets are limited by the fact that they are not very granular because average blood pressure reading postoperatively is every 4 to 6 hours. And we probably need to do a better job with that if we really have to make a difference in the postoperative period. Dan Sessler has already shown this. He did a post hoc analysis on POISE 2, and he showed that if you just focus on this area right here, post-operative day 1 to 4 hypotension, it was associated with 3 times as much harm or the risk of harm compared to the same hypotension exposure in the intraoperative period or on PACU admission or post-op day 0, right? Same exposure to hypotension, 3 times as much harm in the post-operative period. We have done some work. I've did continuous monitoring of hemodynamics in the post-operative period, and we've shown that hypotension is extremely frequent post-operatively. And based on conventional monitoring systems, we miss hypotension at least 50% of the time. I have more ongoing data in the works right now, and you'd be surprised at what we're missing. Liam and colleagues published this. This is from the Netherlands. Not only did they establish that postoperative hypotension is common, they established a threshold. A MAP of 75 was about that watershed line where below that, any exposure to hypotension more than 2 to 4 hours was strongly associated with myocardial injury. So now, not only do we have postoperative hypotension, we have an association with myocardial injury. I've given you all a lot of data to digest. I just wanted to bring up this slide and say, if you ever want to really read about whatever I've just said in the last 10 to 12 minutes, please go and look at this data that we've published with these 2 excellent reviews with Dan and Bernd Sagel, covering the entire spectrum of perioperative hypotension. But going on further, I'm going to take your patient on the hypotensive journey to the ICU. Same problems in the ICU. This is SICU data, and as patient gets more hypotensive from a MAP of 87 down to a MAP of 68, the harm associated with the increased risk of myocardial injury and mortality is very, very significant. Again, pressures that we would normally conceive as fairly okay for our patients. Talk about hypotension in the postoperative ICU. We've replicated these findings in various data sets. So again, a MAP of about 75 to 65 appears to be that watershed line in the postoperative ICU. And I've harped on this a lot of times, but hypotension also occurs in the ICU at critical moments. So one critical moment is when we intubate patients in the ICU. When we intubate patients in the ICU, they tend to get hypotensive soon after intubation. And this is data that we published based out of a prospective trial we did where we recorded blood pressure data immediately prior to and after intubation. This was a multicenter trial across about 10 to 15 sites all over the country. We built a hypotension prediction score for post-intubation hypotension in the ICU. One of the factors in our score was a MAP less than 65, or a systolic pressure less than 130. So what I'm trying to again say here is that MAP matters one way or the other, whether it's the intraoperative period, the postoperative period on the general care floor, or in the ICU. Yes, we need more precision medicine guided targets, but we cannot forget the value of hypotension. Now, all of this retrospective data, we do need some randomized controlled trials. Emmanuel Fouchier's group has done one RCT, 300 patients, published in the JAMA. It's good work because it's a randomized trial. They did look at 2 different targets. Their blood pressure targets were a standardized, individualized management, that's about 10% of baseline, versus reacting to a systolic pressure less than 80. They found that patients who were maintained within 10% of baseline did way better. So this standard treatment right here, the relative risk is about 0.73, which means that there's a 30% risk reduction for those who were maintained close to their baseline. And it is randomized trial data that clearly shows that, again, blood pressure makes a difference in outcomes. What's on the horizon in my institution? I'm actually doing some of this work. So one trial I'm doing right now, I'm putting patients in ambulatory continuous blood pressure monitoring, sending them home with continuous blood pressure monitoring. They bring back their blood pressure monitors, and then we monitor them again in the first 24 to 48 hours after surgery. What we're trying to establish is what is a true preoperative baseline, and how does preoperative hemodynamic fluctuation affect postoperative hemodynamic fluctuation. Again, coming back to the point of really trying to understand where our patients live before they come in for surgery. We've also just finished a continuous portable blood pressure monitoring trial on the postoperative ward. This is a prospective cluster randomized trial with myocardial injury as one of its outcomes. This will be interesting because based on all the retrospective data, we've established associations, but do we really feel that improved monitoring in the postoperative period makes a difference? We'd hopefully be able to say with this work. The other interesting thing on the horizon is the Guardian trial. It is going to be one of the world's largest randomized trials, planned enrollment of about 6,000 or more patients looking at blood pressure-related postoperative outcomes in non-cardiac surgery. Cleveland Clinic is leading this, and we're one of the enrolling sites. I'm very excited with the perioperative hypothesis here, that an intraoperative MAP more than 85 and a target postoperative systolic pressure more than 110 would reduce a composite of major cardiovascular complications in 30 days after non-cardiac surgery. And the reason I'm excited is that finally we're starting to look at the continuum of blood pressure within and outside the operating room. Frequency of blood pressure monitoring is really important. All of us would like to monitor blood pressure continuously, but for now that means putting A-lines in all of our patients. We don't want to do that. We don't always want to be tethered to non-invasive blood pressure cuffs. So what should we do? A-lines help. We've shown this. We've shown that arterial catheters detect twice as much hypotension as compared to non-invasive blood pressure. That's fairly obvious. You put more A-lines in, you detect more hypotension. Does it really matter? Well, if you allow the end user to have access to continuous blood pressure monitoring, then it makes a difference. This is not arterial catheters. This data here is from non-invasive continuous monitoring, and in the arm that was exposed to non-invasive continuous blood pressure monitoring in the operating room, not only did they detect more hypotension, they treated more hypotension, so that group had a significant difference in the amount of time-weighted average MAP less than 65. This I bring up because I want to tell you all that it's very easy to get yourself different kinds of monitors and start continuous monitoring, whether it be on the ward or the ICU or the operating room. But always, always think about these three steps. This was an editorial that we published, and we really wanted to emphasize the fact that validation, the number one step, is super important when you look at monitoring data. It's no good having data without any validation as you subject your patients to these monitors. Number two, plan to do interventional outcome studies. And number three, the most difficult part, arguably, is just the implementation in clinical practice. So hopefully, you all are going to go through this, but I want to highlight some of the available non-invasive continuous monitoring data that does make a suggestion that this is accurate. So way back 2012, this is the NextFin system. Both the systolic mean and diastolic and in fact pulse data is fairly accurate comparing it to invasive arterial lines. And then more recently, this is a cardiac surgical population. Again, within the realms of acceptability is most of this validation data looking at continuous non-invasive blood pressure monitoring. The ICU is no different. I practice in the ICU, and the bottom line is we tend to put a lot of invasive lines in sicker patients. However, patients still have complications after these invasive lines come out. Ideally, we want invasive lines to come out quickly because invasive lines are associated with complications themselves. And for me, I look at data capture and trying to publish all of this retrospective data. One of the biggest criticisms is that if we don't have a continuous data monitoring system, then we have incomplete capture of data. So the big limitation when we try and publish 500,000 patients is that in the absence of continuous monitoring, there is not enough data to establish true signals of harm. Adequate blood pressure also does not equate good perfusion. This is microcapillary circulation from a trial where we were looking at a new novel vasopressor in the ICU, and on one side here is a healthy patient, on the other side is a late septic patient, and I don't know if I can play these videos real quick. What you're able to appreciate here is the sluggish microcapillary flow in the patient with septic shock. Both of these patients were at a MAP more than 65, but the septic patient was on 3 pressors. Again, getting to a good map does not always equate good flow. So what do we need to do? We need to look at not just MAP, but also cardiac output and at least systemic vascular resistance. We hope to be right up here, that as the MAP goes, so the MAP is drifting down, and the SVR is also low. Someone's given a vasopressor here, increased afterload, and the cardiac output has stayed stable, and the MAP has responded adequately. This is where we want our patients to be. Unfortunately, a lot of times our patients are right here. So we've given a vasopressor, increased afterload, MAP has gone up, but the cardiac output has gone the wrong way. In the absence of looking at this data, we do feel that just bringing up a blood pressure is fine. Clearly, it's not. And the reason it's not is that we don't focus enough on cardiac output. So not going to go into this. I know all of you all know what cardiac output is, but understand that preload, contractility, and afterload are all equally important. We need to look at them. We need to be aware of where our patient is on the Frank-Starling curve. Preload increase is not always the answer, although it's our reflex. When the patient has hypotension, go get some fluid, give him a liter of fluid or 500 cc's of fluid, or just go give a vasopressor. That, again, is not always the most appropriate answer, especially in patients who have diseased hearts. That really narrows what they can handle in terms of less fluid or more fluid. And if it's not fluid, then again, is it contractility or afterload? Clearly, afterload increase always is not the right answer. This is, again, data that we presented at the IARS meeting. It's not published as yet. We looked at 25,000 non-cardiac surgical patients at my institution, and we established a fairly strong relationship of the intraoperative use of phenylephrine and postoperative AKI. And the reason, again, there being that the non-judicious use of an afterload increasing agent every time a patient is hypotensive without looking at flow parameters is obviously going to cause harm to vascular beds in other organ systems. So I'm going to hand this over to Simon now, and he is going to actually look at the next steps, right? We've established some evidence, and Simon's going to try and answer some of these and other questions. How do we effectively prevent hypotension? How do we treat it once the risk is evident? How do we decide this balance of contractility and afterload that I've talked about? And really, how strong is that evidence, and how do we take it to our daily practice? I thank you all for your patience, and I thank you all for looking through my slides while I was presenting.